Hello, everybody. Good afternoon or good morning, depending on where you are in the country. My name is Garrett Schmidt, and I'm the CEO and managing editor of VBC Exhibit Hall. And I'd like to welcome you all to today's live webinar hosted by Calcium Health. And it is called The Future of Value-Based Care, From AI Insights to Continuous Predictive Care. I'm very excited about today's topic because I'm very personally interested in anything AI right now and value-based care. A lot of great material. I did get a little preview here, so I think you're really going to enjoy it. A few items of note before we get started. Everyone has joined today in listen-only mode, so you don't need to worry about turning off your camera or muting your microphone or anything. We can't see you or hear you. However, as I always say, we do want to hear from you, right? So we're going to have some time for some Q&A towards the end. And if you have a question at any time throughout the presentation, go ahead and drop it in your control panel. There's a place specifically for questions there. And we're going to get to as many as we can. We have a big audience today and a lot of material to cover. So if we don't get to yours, don't worry. Someone will reach out via email to make sure you get your question answered. Also, the session today is being recorded. So what's going to happen is when we conclude, maybe about an hour or so afterwards, you're going to receive an email that will have a link to the recording as well as to the slides so that you can download those and reference those later on. And that way you can refer to it later, share it with colleagues and friends, and we hope that you do. So without further ado, I'd like to introduce today our speaker. We have with us Mr. Ray Villar, and he was with Calcium Health, and he is the digital architect there and is going to help us and be our guide today. So Ray, I'm going to turn it over to you. Welcome.
Thank you so much, Garrett, and thank you everybody for joining us. Again, I'm Ray Villar, and today, just to get started, just to kind of give you a quick overview, if you don't know what to expect, we're going to talk about the next evolution of value-based care. One that moves beyond retrospective reporting and into preventive, preemptive, and predictive care at scale. We're going to explore how AI predictive analytics and digital health platforms are enabling organizations like yourselves, I'm hoping, to identify risk earlier, intervene sooner, and continuously guide patients between visits, all while protecting the margins, in risk-based contracts. And again, as Garrett mentioned, if you have any questions, if you have any comments, or please drop it in the chat on the right. Now, quickly, this is our agenda for today. Not too complex. We're gonna do a little bit of introduction, then talk about predictive care in today's risk world, then discuss predictive analytics, and then from there go from prediction to prevention. And then also talk about the financial impact and VBC performance issues regarding this topic. We'll then have a Q&A session at the end, followed by our kind of quick wrap up, some key takeaways and next steps coming up. So again, my name is Ray Villar. I am the digital solutions architect here at Calcium. Our website is calciumhealth.com. I also was up until recently adjunct professor at UW Stout for information and communication technology. That's where I got my graduate degree, where I focused my studies a lot in analytics and also marketing, and product security. So I kind of was able to define my graduate study, which is great because it really fit in what we're doing here. I've also had about 2 decades in digital health and health technology, especially in the payer and provider space, but really focus on digital health and technology. Here's my contact information on LinkedIn. If you'd like to connect with me on LinkedIn, would love to, and love to continue the conversation with you. Also, before I really jump in, I want to mention that and also invite you all to please join us at 2 upcoming events. One is HIMSS. If any of you are coming to HIMSS, please join Garrett and me there. It's March 9th to 12th, so just a couple of weeks away. If you are coming to HIMSS, I'll tell you what, please drop a line, a note here in the chat. Let us know you're coming to HIMSS. Garrett and I are actually working on a special event to invite everybody to join us for a little party, I guess. So if you are coming, please let us know. Drop a line in there, and I will send you a special invite. But we'd love to see you to share some insights. Get into some really nice discussion about our, value-based care, and also we're thinking about doing some live podcasts from the event. Again, please drop some. We'll talk more about this later at the end. Also, there's a VBC conference in Nashville, a bit smaller. It's near, as you can see there, right across the street from Vanderbilt University. Now we're an exhibitor and sponsor there, and we have a few free tickets available if you'd like to join us at that event. And again, just reach out to me, and I'll mention this again at the end. So now let's go ahead and jump into this. And I want to talk about our central thesis here before we get started, to make sure we're kind of are clear what we're trying to do. If there's one central idea, especially that I want you to walk away with today, it's this. In value-based care, you don't win by managing complications. You win by preventing them. Reactive care, waiting for the admission, the ED, emergency room visit, or the complications, erodes that margin, especially in downside risk models. Predictive analytics and AI, on the other hand, gives us the ability to intervene earlier. And with digital platforms that continuously engage patients, it allows us to scale prevention without having to scale headcount. And that's a key thesis here we're going to talk about, that value-based care is intended to improve what we've had, address the problems, but it hasn't realized its full potential. But we have the ability to do so, I believe, and that's what we're going to talk about today with this presentation. Now, next, I want to talk quickly about the evolution of value-based care. Excuse me. We've moved over the past decades from fee-for-service to quality incentives, and now into full risk arrangements. But here's the important point. Most organizations are still using tools built for the retrospective area. The next phase of VBC is predictive and continuous care, made possible because what we're seeing in AI, and what the new applications in AI that we're seeing continuously evolving and developing almost at light speed. But this is where risk is anticipated and not discovered after the fact. And this is a critical juncture, a pivot point we're at in value-based care. And kind of driving that, the driving force behind that is really the financial reality of value-based care. Because in every VBC population, I think we all already notice, I'm speaking to the choir, a small percentage of patients drive a disproportionate amount of cost. In some case, some statistics we've all seen is that as few as 5% of patients account for almost half of all healthcare costs for many hospitals and programs. So the question is not whether cost exists. The question really that we're now able to tackle and must tackle is whether they're predictable. Because if they're predictable, then they're potentially preventable. And in most cases, it's with chronic deterioration, medication non-adherence, and post-discharge instability. The signals are often there before the event actually occurs. Now, before we go further, I do want to kind of throw out a quick poll. And Garrett, you want to jump in on this first kind of fast audience poll that we're doing?
All right, yes, I'm going to pull this up, and you should see this on your screen here. And the first question is this: how confident are you that your organization can identify rising risk patients before they become high cost? And again, you should see this on your screen. And by the way, this is anonymous. We're going to have a few of these today. This is anonymous. It's just for fun. But we are going to show the results, so that way you can see where you stack among your colleagues. And again, if you want to choose between, we're very confident, we use predictive analytics regularly. We're somewhat confident, we use basic risk stratification. Limited confidence, mostly retrospective data, or not confident. We typically react after events occur. And again, this is anonymous, so feel free to answer honestly. No shame here. Again, we're just trying to get a kind of a handle on who's in the audience today, and we'll share the results here momentarily. So it looks like most folks have voted, so I'm going to go ahead and shut it down in 5, 4, 3, 2, and 1.
All right.
Okay, Ray, are you able to see this on your screen? And if
Yeah, I
so, would
am.
you mind reading
Yeah.
out the
So
percentages for folks who are
So the
calling in?
number one answer, is, accounting for 52% of those who responded, is somewhat confident we use basic risk stratification, and that's actually a great answer. And that actually it's not surprising because that's where we're at today. Is risk stratification, and we'll talk more about this later. That risk stratification is a great place to be. 2 years ago, because risk stratification is nice. It helps, but it's static. What it does is it groups people. It puts people into groups, but then it doesn't go beyond that oftentimes, and typically. Now that's followed with 26% at limited confidence, mostly retrospective data. 19% of you responded very confident that you do use predictive analytics regularly. That's great. So there's about 20%. That's almost 20% of attendees here are actually moving into predictive analytics. And that's part of the trend that we're in right now. That's not just the bleeding edge or the leading edge. It is the required edge that we all have to be focused on, especially now with the speed of AI proving itself in healthcare as well as other industries. We're now able to do predictive analytics, and that's what we're going to talk about more today. Only one of you actually mentioned that you're not confident at all, and you're not doing any of that. Is all retrospective. That's fine. You're not alone. There's a lot of people out there, a lot of organizations out there still in this situation. But hopefully after this, you'll have a better understanding of what steps to take and kind of understanding what, how to move forward. Now, the problem with most VBC organizations, as we kind of saw with that poll also, is that most organizations are still reactive. And we will, even with a lot of the predictive analytic programs out there, they still rely primarily on claims, analyzing claims and running predictive analytics models based on claims, which at best are only 30 days old, but typically are between 60 to 120 days old by the time they get run through that model. And then after that model, when they actually get back to the healthcare organization, the provider, the hospital, or the ACO, they're probably already, way more than that. So sometimes they could be up to 9 months old already. And so you haven't had that update on those patients and where they're at, where, how, if they've deteriorated, if they've gotten worse, or if they've gotten better, or have they, or if they're even part of the system anymore. And again, that's the problem with looking backwards. Despite advanced contracts, again, most VBC operations are still structurally reactive. Claims data are delayed, as I mentioned. Risk scores are static. Care managers work off of lists generated weeks or months after risks increase. Basically, we're looking at medicine with through the rear view mirror in a risk-based world, not where we want to be. And the cost of that delayed intervention, is there are costs. By the time that patient shows up at a high risk, as high risk in traditional reporting, the financial impact has already occurred. So we might get insights because of this analysis, but we've already incurred the cost. Because delays lead to admissions lead to cost overruns, and cost overruns erode the shared savings or create downside risk exposure for value-based care providers. And that's one of the things that still where risk stratification is nice, it still hasn't fully solved this problem, this challenge. And it's important too to understand the difference when I talk about reactive, predictive, and preventive, because predictive analytics is the bridge between reaction and prevention. Reactive is where we're at most value-based care organization are today, whereas we respond after the event. We analyze the data weeks, if not months after the event, and then come up with workflows, hopefully based on that. But unfortunately, by that time, it's dated and may not be as effective, and oftentimes it will not be as effective. Predictive and preventive, this is where AI comes in, especially. But also expands the scope of data being inputted beyond just claims data. Because with predictive, we're not just responding to the event, we identify the increasing risk, and then couple that with a preventive patient engagement platform. We're able to intervene earlier and intervene and care and intervene continuously, provide care continuously without actually adding to the staff burden using digital health platforms that are now available today. And we'll talk more about that in the upcoming slide. And with that, we want to do a quick second fast poll, approximately, and actually, go ahead, Garrett, if you want to read this out.
Sure thing. All right, so approximately what percentage of your interventions are reactive after an event? Okay, is it 0 to 25%? You're looking more at 26 to 50%, 51 to 75%, or 76 to 100%? I'll be impressed if there's any of you that are the 76 to 100%, but we'll see. Who knows? I'd love to be surprised here. So let's see. We've got the results are still coming in, and again, if you're just joining us later, we have a couple polls that we're doing, or several polls we're doing today. These are anonymous, so feel free to participate, and we're going to share the results here shortly, so you can kind of see where you stack among your colleagues. Okay. Yeah, well, like the results have slowed down here. I'm going to close it down in probably another 10 seconds. And then we'll put up the results. Okay, I'm going to shut it down in 5, 4, 3, 2, and 1.
Wow, I'm actually a little bit surprised at this, and happy to see it too. Is that we do have a small percentage about are in that 0 to 25%. We don't have anybody in the 76 to 100% range. The leader is actually about half of respondents said that about 26 to 50% of their interventions are reactive. And then another third, 33%, said that about 51 to 75% of their events are reactive, which means that we're reacting after the event. And this is not a surprise. This is basically where the industry is. The good news is that we don't have anybody at 76 fully reactive. So the fact that there's none of you are saying that you're at 76 to 100% reactive means that there are movements for more preventive medicine. Whether or not it's driven by predictive analytics or not, we do have a lot of organizations do have preventive medicine, preventive health programs already in the works. All right, let's go ahead and jump forward to our, continue with the presentation. What I want to talk to before we move further is kind of talk about what we mean by predictive analytics, because most of you have probably heard that term quite a bit. I've been, knee deep in predictive analytics ever since grad school, and did a whole slew of analytics courses. But especially in healthcare, one of the things to understand, and especially in today's environment, is that predictive analytics is not abstract. We're not talking about abstract AI here. We're talking about identifying, for example, which diabetic patient is trending towards escalation, which post-discharge patient is destabilizing, which hypertensive patient is drifting out of control. That's operational intelligence. And what it means is that what we're doing with predictive analytics is that we're shifting priorities in real time. One of the best description about this that I've heard is that by using predictive analytics, especially in healthcare and health data and ongoing health data, is that we're going from, hey, who was the most expensive patients that we had, or potentially the most that we've had in the past year or the past few quarters, to who will be the most expensive this quarter or in the coming quarters or the coming fiscal year for our organization. That's a huge step. And the fact is, we have the tools to do that now. The combination of not just building on the claims data-based analysis that we've done in the past with risk stratification, to now include, almost real-time EHR, definitely real-time health monitoring from the hundreds of of medical devices and wearables and health apps out there to get more real-time, but also a longer longitudinal data workflow to analyze, so that our AI models are now able to predict who will be the most expensive patients out there. Let's see. Next, I also want to kind of talk about retrospective dashboards. Tell us who are expensive, but predictive models tell us who is about to become expensive. And that shift alone changes how care teams prioritize their time. Now, I do also want to talk about, and I kind of have mentioned this already, about data sources. The problem with where we're at now, especially even with risk stratification, is that it's all based on claims data. Okay, prediction required, but especially predictive analytics and predictions in general and forecasting requires more than claims data. It requires real-time clinical data, device readings, patient-reported inputs, medication adherence signals, all unified into a continuous intelligence layer. And within this, the kind of the goal with all of this data, and especially with predictive analytics in the realm of value-based care, is how do we identify the patients who are rising in risk? Because the signals are typically already there if we listen, or if we were able to integrate that data and listen to that data. Because the early signals appear days or weeks before major cost events. And the goal of predictive analytics combined with preventive care is to intervene during that early signal, not after the hospitalization. You still do after the hospitalization, but before the hospitalization that actually drive up the costs. Because we already, and our models are already kind of retrofitted for this on a reactive basis, looking at A1C levels, BP, blood pressure levels, missed, medication, or post-discharge, complication. But if we see some of the signals ahead of time that lead to major events, we're able to, using AI, using those same models, but using more data sources, we're able to identify patients who are rising in risk and pose greater potential for prevention. And now the problem too with risk stratification, and even with predictive analytics today, is oftentimes they're not connected to actually to care, that the digital healthcare that can actually make an impact immediately. Because the problem with a lot of a lot of what's happening even today with some of the nascent predictive analytics platform is that you don't you have insight, but we don't have the action, and insight without action is useless. Because prevention doesn't happen inside the clinic alone or in those statistical analysis. Continuous digital engagement is what's needed to allow providers to guide patients between visits, which is where most risk escalation occurs. So with that, oftentimes today there's a reliance on dashboards. Unfortunately, dashboards don't reduce admissions or active and proactive intervention. It's active and proactive intervention that actually reduce admissions, and it's predictive insights that must be paired with these with scalable intervention to really drive our cost lower. And continuous care between visits lets your digital health platform convert your analytics into automated check-ins, medication reminders, symptoms monitoring, lifestyle guidance, and we'll have examples of that coming up. But this is where I'd like to say, this is where the rubber hits the road. This is when your actionable analytics actually becomes action. And oftentimes that's what's missing, because oftentimes you have the analytics, you have the data, you have the insights, but it's handed off to somebody, and then oftentimes many times they're lucky if they have a workflow ready for that, those insights. Oftentimes though, but then even they have to create their own workflow and then they have to apply it. With today's patient engagement platform, so you don't need that heavy transition period where oftentimes things fall through the cracks. And so Here's an example for intelligent intervention. On a high level overview, it's about predicting, preventing, and preempting. Predicting is where where risk stratification happens a lot. Excuse me. Where we're able to identify population or discharge cohorts with higher risk of potential readmission. But with predictive analytics, it takes that a little bit further. It then takes that group and analyzes them continuously constantly check and monitor them for signals that their risks are increasing. And this, and by the way, they don't have to come to the hospital for this. This is something where a simple Fitbit or a home Omron blood pressure cuff, or even the CGMs that many diabetics already have attached to their shoulder, their Dexcom or Freestyle Libre, can provide that information. And if a platform is able to pull that in and feed it into its analysis on a continuous basis, it then can set alerts and predictive analytics alerts based on that data. And then from there, we can do prevention. We can provide health literacy pathways, or maybe monitor patients, monitoring pathways to make sure they're adhering to care plans. And then from there, if the signals continue to come and are so strong, that's when you see key vitals being continuously and automatically monitored, you can see the increased risk, and that's where then you have options for preemption. So imagine, for example, a diabetic patient trending upward. They're diabetic. They're on metformin and maybe some statins, and they're on a care plan that encourages them to lose weight. You might even put them on GLP, or something like Ozempic or Mounjaro to help them control their weight, and which will also possibly positively impact their diabetes. So you put them on there, but oftentimes you wait 2 to 3 months to see them again to see if it worked. Well, with continuous monitoring, if they have a CGM, for example, but also an app that monitors whether they took their medication, that monitors their weight, that monitors their different their heart rate, their other vitals. Your predictive analytics tool can then try to can be on alert for signals that may indicate, that shows whether or not they're actually following through and are improving, or they're not. And the nice thing about that is a lot of people will be following through, and you'll see the ones who are doing well. But with a continuous predictive analytics platform, you'll see the minority who are not doing as well and may need outreach. And what that then does is that it gives you the opportunity to reach out to them in between visits, so that to nudge them back on track. Because as I've had, in many, I've learned in many discussions with providers, is that the problem isn't a diagnosis or care treatment plans. It's keeping people on track. How do you keep them on track, to save their lives, to improve their health? And that's where predictive analytics coupled with continuous care and targeted preemption allows you to be able to keep more patients on track without creating this huge burden on your staff of having to contact every patient on a regular basis. You can do that without. You can now scale without. You can now are able to scale without a headcount. Oh, I'm sorry. This is the what I meant to go through. Now, the other thing too about when you're able to connect a patient engagement platform or for continuous care, you're able to scale up using, based on your predictive analytics insights without having to scale headcount. This doesn't mean that you're getting rid of professionals on your team. What it does mean is that you're able to allow automation to handle the predictable 80%. Freeing up your clinicians to focus on the more complex 20%. That example I gave you for that, let's say you have 100 diabetic patients that you're running through a pilot through a program here in a cohort, and 80% of them are actually following through. They're making nominal, if not really strong improvements, but then you have the 20% who aren't improving. their A1C levels are continuing to increase or get even worse. Their weight is continuing to get worse. You're able to focus on those 20%, on a more continuous basis rather than rather than every 2 or 3 months when they come in for a checkup. And that's how we're able to scale personalized care without scaling our overhead, our head count, and cost. Now, kind of bringing it back to value-based care is that preventive analytics, helps us improve predictability, but it also smooths cost variability and it protects margins in downside contracts. In downside risk, volatility is dangerous. Predictive and preventive care stabilizes that financial performance. But so again, that's why I kind of mentioned too on the right-hand side there, you'll see that that not only does predictive analytic help us to lower costs and improve shared savings and reduce downside risk, but it also impacts our quality measures and rewards, our HEDIS and STAR measures. And because with predictive outreach, we close care gaps before reporting deadlines, and with continuous engagement, we through digital platforms and not with nurses having or other staff members having to make calls on a regular basis to every patient, but just to the few that your predictive analytics tools have identified are in most need of a nudge back. That's where quality improves proactively, not retroactively. Now that does bring up the question of what capabilities are required to do this. Because it may sound to some of you that, wow, this is really great, but how hard is it to put this together? As most of you using AI today, it's actually more affordable than past models and past solutions that most organizations have actually invested in. Because the next generation of value-based care organization really only require these 4 capabilities, to allow predictive analytics and continuity of care. One is unified data, and oftentimes, like for us, at Calcium, this is one of the things that we do is we help unify the data, and then run the predictive analytics models, and then put them in a continuous digital care program that helps prioritize care. And that this is really the 4 capabilities, though, internally that you're going to need to have is being able to unify data, having predictive modeling. And a lot of predictive modeling, it really is based on the models that we're already using for risk stratification. But it's fine-tuned more on a continuous basis, so that instead of running patients through a risk stratification model one time, with predictive modeling, it's a continuous thing. You run them through. As new data comes in, it keeps reanalyzing, and then based on that, it sets alerts based on who needs more interaction and which ones just need continuous monitoring. And you can have pathways for different categories of patients. Now, with that, I do want to talk about. I do want to bring up our third and final poll of the day. And Garrett, do you want to pull this up?
All right, it is up, and I'll go ahead and read it as I did before. On a scale of maturity, where would you place your organization? And again, for those of you who are just joining us, this is anonymous, and we're this is just for us to kind of get a gauge of who's in the audience, and we'll share the results here. But where would you place your organization in terms of maturity? Are you reactive? Or is it reactive or retrospective reporting only? Is it basic risk stratification, emerging predictive analytics, or advanced AI-driven predictive care? Or are you fully continuous and preventive model? Or do you have a fully continuous and preventive model, rather? And so we're going to give it a few more seconds for everyone to respond here, and then we will show the results. And looks like most of you have responded at this point. I'll probably close it down another 10 seconds here. And 5, 4, 3, 2, and 1.
Right.
All
Right.
right.
So no surprise, nobody's a fully continuous or have a fully continuous and preventive model yet. But my prediction is that probably this time next year, that percentage will probably be in the 33 to 45% range. Maybe half of you will be in that at that point, because that is where we're going. That's where we need to be going to really rein in costs, to make the big impact on costs that that is the promise of value-based care. But 47%, the leader is that a lot of you are moving towards emerging predictive analytics. That's great news. Congratulations. And 40% are using basic risk stratification, and a small percentage are in that reactive mode still. And there actually is a group that are and one of you is actually in that advanced AI-driven predictive care already. They're doing that, which is great. Would love to talk to you more about that. What your experience is, but this is actually a pretty spot-on snapshot of where we're at as an industry. All right, now let's go ahead and move on and start wrapping up a little bit, and we'll have a Q&A. But again, as we mentioned before, the future of value-based care is not episodic. It is continuous, it is predictive, and most of all, it's preventative. And again, the key takeaway that I would like to stress here is that if you wait for the admission, you've probably already lost the margin, because VBC depends on predictive, not retrospective insights, especially moving forward. The future of value-based care depends on those predictive insights. And AI identifies those rising risk patients before costs escalate, not after. And continuous digital pathways help improve that adherence and outcomes based on AI insights in almost real time. And leading organizations are scaling personalized scale while still protecting margins using this model. A little bit about what we do here at Calcium and why this is a passion for me is this has been part of what I've been doing I've been with Calcium from the very beginning, since we started in 2018. But I've been an AI geek, since for quite a while now, but especially after Thanksgiving 3 years ago, some of you may remember, was when ChatGPT 3.5 came out. And I had heard about it in different chat rooms that I was, tech chats that I'm part of. And so day after Thanksgiving, I downloaded set up my account and started into it. And that first weekend, I think I only had like 6 or 8 hours of sleep that entire Thanksgiving weekend, because I was just diving into it, trying to see what it can do. And it was just amazing. And I remember writing a long memo to our executive team the Monday after that Thanksgiving 3.5 years ago, and say, hey, we need, this is going to change our entire industry. And in many ways, we quickly adopted that. 3 months after that, we actually launched our Calcium AI Studio that creates the pathways, where we use AI to generate pathways personalized for each patient based on their condition. And this is also where we work with our partner Pulse Data, and use their predictive analytics models and engines combined with our Calcium core. We're able to integrate with hundreds of medical devices and wearables. We pull in EHR, and we're able to combine that with claims data and along with that continuous patient monitoring data to provide that continuous monitoring and tracking that gets fed into predictive analytics models. And then the insights that come out of it, our platform is able to turn that into care pathways for that patient to keep nudging them back on track, and to alert you, the provider, when somebody actually needs more than a digital pathway, where they may need a text message or a phone call, or maybe a home visit from one of your home visit nurses. Again, the key thing here is to prevent that costly readmission that will drive up the cost and lower our lower margins especially if you're in that downside risk model or even the shared savings model. So now we kind of want to open it up to Q&A. I don't know if you got any questions, if any questions came in while I was kind of chatting away, Garrett.
Oh boy, they did. Yes, they did. And so if you have a question, by the way, that you'd like to ask Ray, go ahead and drop it in now to the questions area. We've got, again, a big audience and a lot of questions here. So we're going to try to get to as many as we can. If we don't get to yours, though, don't worry. Someone will reach out via email to answer it afterwards. So in no particular order, let's go ahead and dive in. First question is this. How do we know when our organization is ready to move from reactive to predictive care?
That's a good question. I guess I would say that at the baseline kind of level, you're ready when your downside risk is material enough that the reactive management that you're using becomes financially dangerous. Now, on an operational level, readiness really depends on the stuff that we talked about before: access to real-time data, or having access to having a platform that gives you access to near real-time data, defined care management workflows, but also leadership that's aligned around prevention, and probably a willingness to automate some of these routine engagements, which not only lessens the burden on your staff, but for those identified patients, but probably for a lot of other patients who might not also be identified in your predictive analytics results. I guess the bottom line is that if you're still identifying high-risk patients after that admission occurs, that's probably a signal that you've outgrown your reactive infrastructure. Hope that answered the questions.
No, that's great. I think you did. Okay, next question is this. What is the difference between risk stratification and predictive analytics?
Good question. I think I kind of hinted at this before too, and so I'm glad somebody asked this. But all right, here's the simple answer. Stratification is static. Predictive analytics is dynamic. Because risk stratification, any of you who've used it and understand it, it classifies patients based on their historic factors, their historic claims data, and puts them to a group. Just basically says, all right, this is the group they're in, and then gives providers this grouping of patients and say, hey, these are the ones you want to look at for this. This is the ones you want to look at for that, and that's it. It's a one-time kind of classification, oftentimes based on data that's months, sometimes a year old, and you haven't had much after that. And so when they give you that list of patients, oftentimes your staff will then have to go back and check on these patients and kind of analyze, do a really deep dive to see, hey, does this still apply for these patients? Are they even still part of our system? And what are the current readings? Does it still apply? Have they improved to the point where they're not as high risk, or have they gotten worse that they've actually gone to a high, or put up to a higher tier level of risk? So, whereas with predictive analytics, you're able to identify the trajectory changes and continuously update that, which allows you to detect the early deterioration for that percentage of that group that may have been identified in risk stratification, to be able to really focus on them even more. And again, it continuously updates risk probability. One way to look at this too is that, and this is part of what we work with our partner Pulse Data, is that we use risk stratification first to identify the larger group that should be looked on. But then with predictive analytics, we then put that bigger group into predictive analytics. And what predictive analytics and continuous care allows us to do is then identify the 20% in that larger group that are at highest risk based on their current data, their current vitals, their current health information that's now almost in real time coming in. And so your staff, your care team gets more current and I guess, more relevant, more timely alerts based on more timely data rather than just a simple categorization. I hope I didn't talk too much about that's basically, I think what I said at the beginning is that stratification is static, predictive analytic prediction is dynamic. It's ongoing.
That's a great explanation, and you know it's implied that AI is right in the wheelhouse for predictive analytics for that reason, right? Because you can take all that historical data and then push forward in a projective way that it'd be hard to do with just analytics alone.
Yep.
All right, next question here is let's see. Speaking of predictive insights, how do predictive insights become workflows?
Oh, another good question. Well, yeah, I guess I want to start at that. Look, if you don't, and this is actually important, the important thing behind this question. I don't know if you thought, whoever asked this thought about this, but if you don't have a defined action pathway, that prediction has limited or almost no value. I don't want to say it was a waste of time, but if you don't have a workflow to immediately apply that predictive insight, or even with and this even applies to with your with risk stratification, that's money lost. You know, yeah, great insights, but if you don't actually have workflows to put into place for that individual patient or that group of patients, those insights are almost meaningless or have limited value, I guess. But what that means, though, is that for every, to really make this successful, every predicted signal should trigger an action. And I kind of have three actions in mind. So, and they're kind of step ladder, so that we gave the example of that diabetic patient who might have, whose A1C levels might be increasing. So one, there's three levels. One is the automated digital interventions where, you can program the pathway based on the, where their A1C is, or based on their weight, where their weight is going, that it can trigger, let's say, a health literacy workflow that tells them, kind of informs about the importance of their condition, or it could be, or it could trigger, for example, on our platform, it could trigger a digital or an automated conversation, feedback conversation with a patient that asks them, "Hey, have you been taking your meds? Are you feeling? Are you having trouble keeping on track? What have been the challenges you're seeing?" So some of the questions that you would be asking if they would come into your clinic, you could ask them, are you do you have any depression level? Are you having trouble accessing medication, or exercising, or doing following your care and treatment plan? You can get that detail, and based on their answers, you can then maybe change their medication or change the care plan. But the second level beyond that automated digital intervention is the case manager, care manager review, where this is maybe where you need to put them on a different care plan, or where you actually need to do an outreach and call them, or send somebody out to visit them. Because the third level is the physician escalation, where you do need to have them come in and see your physician, to find out what's going on, why the medication or the care or treatment plan isn't working. So I would say, that's probably the three levels that you want to have in your kind of the action workflow that you want to trigger after your predictive insight, comes in for that patient.
Got it. Okay, next question is this. Should or shouldn't remote patient monitoring in conjunction with AI be the most effective way to predict?
It is what, it's part of the solution, but it cannot, it's not by itself. So, but definitely for the, the continuous monitoring of the continuous predictive analytics, that is part of that actually kind of describes a lot of the question. But it's making sure you have all that data coming in and it's fed back into your, your care management pathway. It kind of goes back to what we talked about, what all the data that you really need to have a true predictive analytics platform. That remote patient monitoring is a big part of it. But then also, but the problem with a lot of remote patient monitoring platforms is it just pulls in health vitals. It doesn't actually talk to the patient, or it doesn't pull in feedback from the patients. One of the example I have, our platform also has behavioral health pathways, for example, that not only monitors their blood pressure, anxiety levels, temperature, temperature and all of that, but it also monitors anxiety levels. And so every day, once or twice a day, if necessary, our app will pop up a quick feedback prompt to the patient to saying, hey, on a scale of 1 to 10, what are your what are your anxiety levels? What are your depression levels? Are you feeling any triggers? For post-op, one of the things that our pathways can do is, one, it can prompt them on every day, on a scale of 1 to 10, what are your pain levels? Also, if you have a wound recovery, you can have them use their smartphone and take an image of their wound every single day, upload it into the app as part of that pathway, and then on your provider dashboard, your care manager, post-op care manager can see, how their wound might be, healing over time.
Cool.
Those kind of things. So, yes, remote patient monitoring, especially the way it's used today, that term is used today, is an important part of this predictive analytics continuous care model, but not by itself. And again, it's a great place to start, but then but it misses that patient feedback that is still very critical, beyond the health vitals, beyond the blood pressure, the A1C level that's being collected. It's also that patient, because some of the things that might be missing is that, why aren't they taking their medication? Why aren't they exercising? What are their stress levels that might be contributing to this? What are the social determinants of health issues that might be determining to this, that's not being picked up by remote patient monitoring? Yeah, hopefully that helps. Hopefully that
Oh
answers it.
yeah. No, there's a lot there, obviously. So more to come on that. Next question is, you may not have these on the top of your head, Ray, but are there any scientific studies that compare the savings that result from different intervention models that respond to AI detected
That's a great
rise in
question,
risk?
and I actually have been putting some of those together. So if you drop your send whoever it is, please drop your what I'll do is I can share this with everybody later. We'll send a follow-up email,
Yeah,
and
that'd be
I'll
great.
throw some links of some studies that I've found that not just for the different models, but also as I put together this presentation, I wanted to make sure I wasn't talking out of my what. So I'm a big fan of actually doing research and studies that kind of something that was drilled into me during grad school, and so having so I've actually been compiled about 36 different studies just for this presentation that I'm doing here. So and I think some of those relate to those models that you meant that was asked, and we'll share that with everybody in a follow-up email.
Awesome. All right, we have time for probably two more quick questions here. Next one is, how do we integrate fragmented data?
Oh, that's okay. At the risk of this being planted, this is actually something that Calcium has been dealing with for since our inception. Is that one of our goals and mission has been kind of provide a 360-degree view of patient health data for providers, but also for patients themselves. And so one of the things that early on that we connected with was, we're part of, through the Commonwealth Care Quality Alliance, we're part of TEFCA, which includes Epic and Cerner and all the major EHRs. And we're able to exchange data with them, but also pull in patient data from them. So we have access to that. So that's in addition to claims data, we, through our partner Pulse Data, we're able to bring in their analysis. But then we also, one of the things that we've also been working on is making sure we integrate with hundreds of medical devices and wearables. And so we're able to do that now using using a third party, there's a couple of third party networks out there that allows us to be able to pull in quickly all that data. You know, if somebody has a Fitbit or an Apple Watch, or let's say they have a Withings digital scale, or one of those Whoop bands, or an Aura ring. In fact, some of you may know this, but the Aura ring and the Whoop band are the only two devices that are cleared to be in secure government facilities, especially Defense Department facilities. So, if you want to be able to monitor people who regularly go into secure facilities, you can't use a Fitbit, you can't use Apple Watch, but you are allowed to use an Aura ring or a Whoop to collect that continuous data. Just a side note. But again, being able to pull all that data in is one of the things that we do. And then we also have the pathways that prompt patients for input, including, pictures they may take of their wound or their knee, pre and post surgery, that kind of thing. But we're not the only platform that does that. But in fact, a lot of organizations already have disparate tools that do that. So it's a matter of being able to bring that all together. So with that, a lot of times, for us, it's API connectivity. But I'll tell you, none of this would be as possible without FHIR, FHIR, which I think all of you are probably familiar with. That's the interoperability standards that allow us to pull in, but also share health records with permission, with the right security levels, with other providers who are treating that same patient. But that question actually comes to a really key point, which is that all this data fragmentation for the past decades, 5 decades, has been one of the biggest inhibitors, for a lot of growth in not just in risk stratification, but really in predictive maturity, predictive analytics maturity, to be able to really to bring more data in to get a full 360 view of a patient's health, but then also use predictive analytics to then take that 360 view of a patient's health and make predictive predictions based on that, and then assign workflows based on those predictive insights.
Awesome. And I'm glad you brought up the Aura ring, because I heard a rumor that you guys might be raffling off an Aura ring at HIMSS. So
yes, we are.
So by the calcium booth there.
Oh, yeah. Yes, we're giving away an Aura ring, and so if any of you are there, please stop by. Drop your card with us. But again, too, as I mentioned, Garrett and I are setting up a couple of things. One, some live podcasts if you want to join us. But also, we're looking at, we're probably going to set up a little, a networking event with other fellow value-based care professionals like yourself. Just want to really network with each other, but really start sharing some of the insights and experience and discussing issues that are really part of the evolution we're in right now. And again, too, as I mentioned, we have that we'll be we're a sponsoring exhibitor at a VBC conference in Nashville at the end of March. And if any of you are in the area or would like to come, even if you're not in the area, Nashville is always fun. We do have a few free tickets available. Text, email us, or let us know if you're interested.
Awesome. Well, that is all the time we have. So that's a good segue to closing out here. We did have a few questions that I know we weren't able to get to. So again, if you are one of those, don't worry. Someone will get back to you. One of the questions, Ray, I'll just have to give a quick preview because we may have to circle back on this one, is what AI systems are best to use? Which I knew that was a juicy one and was going to take a long time to answer. So we may do a whole webinar on that.
Yeah, I'll tell you what, do not use regular ChatGPT to analyze patient health data. If you are, you're breaking HIPAA rules. Because if you use, and we act, because unless you're using a secure, an especially secure and actually non-sharing AI, like we use our own HIPAA compliant version of OpenAI with that ChatGPT that doesn't send patient data back to the mothership. Because if you're using ChatGPT, for example, to analyze a patient data, guess what? You're sending that data to OpenAI, and they will not sign a BA document for anybody right now. Well,
Oh,
they
wow.
will, and for specific organizations that go through some important hoops, but most of these like Grok, Gemini, if you just put patient data in there, you're basically breaking HIPAA rules because you're sharing patient data with another organization who hasn't signed a BA. Again, I know we're running out a little bit.
Oh
Running
man, no, that's an important point. I'm glad you brought that up, Ray.
out.
And again, we may do a whole session on that at
Yep.
some point. We're going to be doing a bunch more webinars this year with Calcium, so very excited to have you guys tune
Yep.
back in. As we close out here, first of all, Ray, thanks again for a fantastic presentation. Always excited to hear from you, and there's always a lot of great material to cover. Head over if you would. To VBC Exhibit Hall, check out the Calcium virtual exhibit booth. It's got a lot of great resources. It's really cool. There's a lot of stuff you can read up on them, and of course, reach them directly through there, but sort of educate yourself on what they're doing and in the space. Also, at VBC Exhibit Hall is the other webinars are archived there that we've done with Calcium, and so you can find out more about AI. Different AI agents and that kind of stuff that we did a really great webinar earlier this year on. So more to come there. But Ray, again, I wanted to thank you for today. Thank you all out there for joining us today. I know you have a lot vying for your time. Hope we can see you at Tim's and maybe in Nashville. And we'll see you definitely on the next one. So thank you all and have a wonderful rest of your day.
Thank you, everybody.
Bye-bye.